Well, good morning, everyone, and welcome to this symposium, The Illusion of Remission. My name is Tim Raine. I'm a gastroenterologist from Cambridge in the United Kingdom, and it's my absolute pleasure to welcome you to this symposium. The name of this symposium is deliberately crafted to conjure up an air of mystery. And it's an air of mystery that I hope in the course of the next hour we can start to unravel for you as we realize that all is not quite what it seems when we come to think about the drugs that we perhaps most commonly use in the management of IBD, namely corticosteroids. It's my absolute delight to be joined today by some absolutely stellar faculty. Professor Dotan needs absolutely no introduction, coming from Tel Aviv in Israel. And likewise, Professor Mark Silverberg from Toronto in Canada. I'm delighted to be joined by you both, and we very much look forward to your contributions. Between the three of us, we're going to take you through a journey. And the journey begins really with looking back at the history of how we've used steroids and really what we currently know about contemporary practice. Iris is going to take us on to look at maybe some of the hidden burden that we're not even conscious of, the unknown unknowns in our management of IBD. Before Mark casts an eye to the future and asks the way that we'll be using steroids, both in future practice, but also in the context of future clinical trials. And then hopefully we'll have some time for your questions. The Asking Questions of this symposium is based upon question cards. You should all have one in front of you that you were given on the way in. Please, please, please do use it. We don't have the opportunity to take questions via the Congress app, so please use the question card to write your questions on, hand them to one of the members of staff around. They'll bring them up onto stage, and we'll look forward to answering those. There is also an evaluation form. You'll notice it has a pre and post evaluation. If you could just take a moment now to look at the pre section and fill that in, and then at the end we'll ask you again to complete the post-Congress evaluation. You'll also be given a scratch card. No prizes for winning this one, but hopefully something to have a little bit of fun with and look through and see the way that uncovering maybe hidden information around the use of steroids can shape your own clinical decision making. And finally, there will be the opportunity to take part in interactive voting. You should all have a voting keypad, which should have been given on the way in. And in case I forget to mention it at the end, please do hand it to a member of staff at the end of the symposium. So with all that said, let's have a test of the voting keypads now. February the 14th, just 3 days away, 2 days away. Or is it tomorrow?
Tomorrow.
It's tomorrow. I've not bought a card yet.
We know your answer now.
Yes, thank you for reminding me of that. So, will you be giving anyone a Valentine's card? 1 for yes, 2 for no, 3 it's a secret, or 4 only to myself. So let's test the voting now. I can see you're voting, the votes are flooding in. Let's keep the polling open just a little while longer. 7 seconds left to vote. Still voting. Oh, what an unromantic lot you are. Okay. So, when we think about corticosteroids, it's worth reminding ourselves that these were indeed the first drugs to really undergo proper therapeutic testing in inflammatory bowel disease in the form of this absolutely seminal randomized controlled trial from Sidney Truelove and Leslie Witt in Oxford in the 1950s, a trial that was so advanced that the first paragraph of the text had to be spent explaining to readers just what a randomized controlled placebo trial was. And of course, this established these treatments as tremendously effective induction therapies for patients with active ulcerative colitis. It took a further 20 years to establish the same data for Crohn's disease in the context of a large North American and European study. But we should reflect upon the fact that these treatments are a firefighting tool. They are tremendously effective at putting out fires, but they are not a fire prevention strategy. Furthermore, there are a number of limitations to what we can currently achieve with corticosteroid therapy. And I don't want to steal any of Iris and Mark's thunder, but I'll just whet your appetite by telling you that they're going to tell you a little bit about how imperfect the outcomes can be from corticosteroid therapy. The fact that these therapies are not in any way effective maintenance treatments, although all too often they are used precisely as such. and furthermore, actually, that these drugs do little, if anything, to induce mucosal healing. But actually, what I want to tell you about is that these drugs have side effects. Well, you know that already, but maybe we don't appreciate just what the full range of side effects are. These are the only drugs in the history of IBD that have ever actually been shown to confer excess mortality, as we see from this very large registry comprising 15,000 years of patient experience in the TREAT registry. And for this reason, as well as the panoply of other side effects associated with corticosteroids, many professional bodies have recommended that we should try, where possible, to avoid using them. So our American colleagues say that we should use corticosteroids sparingly in Crohn's disease and take care to try and discontinue them for Crohn's. And in ulcerative colitis, again, the goal should be to obtain and maintain steroid-free remission. In Europe, we're a little more granular around our definitions. So the Crohn's guidelines from ECCO state that we should try at all costs to get patients off corticosteroids and really define dependency or excess on the basis of an inability to wean patients below 10 milligrams of prednisolone a day or 3 milligrams of budesonide within 3 months of starting that treatment. Or alternatively, corticosteroid dependency in patients who are relapsing within 3 months of stopping steroids or who are requiring more than a single course of corticosteroids in a year. It's not just professional societies who have recognized the importance of this. This is a paper from a patient organization in the UK, Crohn's and Colitis UK. And our patient body has identified corticosteroid-free remission as a key step on the ideal patient journey with inflammatory bowel disease. Likewise, in this Danish study, when patients were asked to identify what mattered to them most around the therapies that they might be exposed to for their inflammatory bowel disease, the most important factor that patients identified was efficacy. They wanted a medicine that was going to provide them with significant, relatively early improvement. But the next most important factor was the fact that a medication would reduce or completely avoid their need to take corticosteroids. And yet, despite all of this, we still know that these drugs are very widely used. So this is a study from Corey Siegel looking at over 16,000 patients in the United States and their journeys with Crohn's disease in this instance. And what you'll see is that corticosteroids are not just heavily used up front, but repeatedly used in the management of patients with Crohn's disease. Indeed, if we look at secular trends, we have these data coming from Canada, effectively showing that really we continue to use these drugs as much now as we ever have done, if anything, possibly with a slightly increasing tendency over time, despite the availability of corticosteroid-sparing strategies. Now, is that because steroids are cheap? Well, undeniably they are. But this is a very interesting healthcare claims database study that looks at the excess costs of treatment care for patients with ulcerative colitis and Crohn's. Now, these figures do not include the cost of therapy. So this is just the additional cost of looking after patients. And what you'll see is that patients managed with oral corticosteroids with both Crohn's and UC occur significant excess treatment costs compared to those patients managed with either immunosuppressants or anti-TNF therapy. In the UK, we started looking at this by developing a steroid assessment tool that enabled us to audit our practice across many centres in the United Kingdom. And this was a simple, powerful tool that we designed for rollout in routine clinical practice. In fact, we captured data initially on almost 1,200 UK patients with inflammatory bowel disease and found that 30% of them had had some form of steroid exposure within the previous 12 months. But actually, if we drill down a little deeper into that, we discovered that around 15% of these patients had had excess corticosteroid exposure within the previous 12 months. And actually, if we were looking for a risk group that was most at risk of either corticosteroid exposure or corticosteroid excess, it was patients with moderate to severe ulcerative colitis. Similar data have come from pediatric studies, this cohort from our colleagues in Glasgow, who demonstrated again, even in a population where we really want to avoid corticosteroid exposure, significant corticosteroid exposure and dependency in children with moderate to severe ulcerative colitis. Now, we repeated that 2 years later and saw that the rates of corticosteroid exposure were relatively constant across the whole of the UK over time. But interestingly, when we look specifically at those centres that had embedded the audit within their practice, what we found was trends towards less corticosteroid excess and indeed statistically lower corticosteroid exposure in these patients. The simple act of auditing appeared to be associated with a reduced use of these drugs. So which patients, other than those with moderate severe UC, are most likely to get corticosteroid excess? Well, here we have data for Crohn's disease, and we can see that at multivariable level, the use of anti-TNF appears to be protective against corticosteroid excess. The management of patients in centers with an active multidisciplinary team was also protective. As I've just told you, participation in a steroid audit appeared to be an independently associated variable with reduced corticosteroid excess. And likewise, patients managed on thiopurine monotherapy had a slight increase in their risk of corticosteroid exposure. And for UC, we have relatively similar data. Now, in the UK, this has led to a number of steps at multiple different levels. So at a patient level, our patient charity has produced an information leaflet about corticosteroids, highlighting to patients the importance of these therapies, but also their limitation. Our Royal College of General Practitioners has produced a toolkit aimed to increase the skills of our general practitioners in the management of IBD, and one of the key components of this toolkit is the need to liaise with secondary care whenever considering corticosteroid initiation. And in secondary care, we've introduced a new series of standards which govern what we think a well-managed IBD service should look like, and key to those standards is the need to regularly audit and monitor steroid usage. So in summary, yes, we have guidelines that recommend the use of corticosteroid-sparing treatments, and yet these treatments continue to be used at high frequency despite our patients' clear preference to avoid them. The most at-risk group appear to be patients with moderate to severe ulcerative colitis, and the simple act of asking the question of yourself, how much steroid am I using in my practice, does appear to be associated with an overall reduction in corticosteroid exposure and corticosteroid excess. So I'm going to thank you for your attention there and pass over to my colleague Iris, who's going to tell you a little bit about what you may not know is going on outside of your management. Iris.
Hello, everyone. It's a pleasure to be the opening symposium for this ECCO in Vienna, so welcome. And thank you, Tim, for actually setting so wonderfully the scene and discussing the use of steroids, drugs that we think we know so well to treat patients with inflammatory bowel diseases. And indeed, it is my role to talk to you a little bit about the hidden figures, so what you may not know about what is going on outside of your care, but actually also in your own clinic, what is going on with our patients. So we all know that corticosteroids are very important therapies for patients with ulcerative colitis and Crohn's disease. It's undoubted. However, we're also aware of their significant side effects for our patients. This was shown for patients with adult IBD as well as for pediatric patients. And because of that, about 10 years ago already, the American Gastroenterology Association already established quality indicators, and you see in front of you what they mean, to a measurement set aimed at increasing patient safety, improving treatment, decreasing steroid use, and decreasing complications related to treatment. And actually, in the last few years, they actually set that as quality indicators measured. And you see in front of you the many quality indicator measures, but you see that two of them, actually, not one, are addressing steroid use. Recommend prescribing steroid-sparing therapy, you're asked to do if you want to keep quality in your clinics, and address steroid-related iatrogenic injury and assess bone health if steroid exposed. So both addressing steroid use in patients with IBD. And the consequences, we think we know, but look at the myriad of side effects that patients that take steroids might have. It's always fascinating to see that these are not just theoretical side effects. And you're all familiar with the excitability, the neuropsychiatric side effects that patients that take steroids report to you on a daily basis. Of course, the changes in carbohydrate and lipid metabolism with overall diabetogenic effect in our patients. The adipose tissue distribution, the bone and calcium metabolism, so both osteoporosis but also the avascular necrosis that might happen to patients and is irreversible. the skin, muscle, and connective tissue. And actually, I've just seen in my clinic a young patient that I know who 20 years ago, and when she was still a child, was treated with steroids and has these horrible purple stria on her feet, which will never go away, and so on and so forth. Effect on the endocrine system, of course, the eyes, the gastrointestinal tract, the cardiovascular and hypertension-related side effects, growth and development, extremely important for the pediatrician among us, and not only we see that throughout life, and of course, the exposure to infections and the immune susceptibility that is associated with the use of steroids. So you are all aware of it, or should be aware of it, when you are treating your patients with steroids. So let's see, these side effects actually accumulate. The longer you treat a patient with steroids, this is a known, but still happens, and this is work that was reported by Bill Sanborn to show that if you're treating patients for more than 4 months with steroids, you see that these side effects are accumulating and the proportion of patients experiencing toxicities increasing. And actually, there are serious side effects that are associated with prolonged, what we used to think is low to intermediate dosages of steroids, usually defined as 5 to 10 milligrams of steroids a day. And we learned, some of us learned from our rheumatology colleagues, say, this is okay, this is low dose. So no, you see that steroid-associated osteoporosis, specifically the ophthalmologic side effects, and the side effects that we are seeing with steroids might be seen also when you're treating your patients with low to intermediate dose steroids. So we want to check again after Valentine's Day success. So we want to check and ask you, in your opinion, if a patient experiences any corticosteroid-related side effects, with whom do they most frequently discuss this with? So with myself, meaning the physician, with the IBD nurse, with their family, or on social media. So please vote. Who do you think patients with IBD discuss steroid side effects with? Be honest. Okay, are we going to see the outcomes? Okay, so I think you were honest, because some of you, and only not the majority of you, think that it is with the physician. Some of you acknowledge the fact that they discuss it with the IBD nurse, with their family, so not with any medical personnel, or on social media. And actually, all of these answers are correct, but you see that the physician is not the major person in this figure. Now, do you fully understand the burden of corticosteroids in patients with IBD? By your own testimony now, the answer is no. And of course, this is supported also by recent information. So we see that clinicians in both IBD specialty clinic and community center may be underappreciating the levels of corticosteroid use. And you see here, this is the overall, this is in the IBD centers, and this is in the community practices. And we all underestimate, whether you ask the healthcare practitioners or the patients in the light blue, you see that across the board, there is underestimation of the use of steroids in your practices. Doesn't matter who you are. And when you're looking in patients with IBD, patients with Crohn's disease actually here, when they're treated in community care centers, this is a survey from Canada and Germany, so representing North America and Europe, they are more likely to receive long-term corticosteroid therapy with lower chance of having steroid-sparing therapies if they're treated in community care centers. And you see the report of corticosteroid monotherapy over 3 months on the left side, and you see here the report of some steroid-sparing agents, in this case the anti-TNFs, but it's also reported for the immunomodulators. So again, in your opinion, where do patients most frequently access corticosteroids? If we said that we're so aware that we shouldn't prescribe them, how do they get them? So from their own stored supply, from primary care, from pharmacists, or from yourselves? Please vote. How do they get these steroids? Okay, and the answers would be in 3 seconds. Okay, in this case, an educated audience, and you read the reported, no, that's too fast. Okay. Yes. So they get it a lot from their primary care, and in some cases, you prescribe steroids to these patients. So patients are more likely actually to have inappropriate and avoidable use of steroids from primary care versus secondary care. So you knew it, and it was recently audited and published. So this is from the Steroid Use Audit, and you see that in more than, in about 1,200 patients that were assayed, you see that approximately 15% of them, and Tim already mentioned it in his talk, were using excessive steroids in this cohort. And when you looked at the patients that used excessive steroids, you saw that 50% of them were probably unavoidable, but almost 50% of those patients were receiving inappropriate, excessive use of steroids. So 50% of our patients did not need to get that. And in many of the cases, in the majority of them, the decision to prescribe those steroids was traced to either general practice or secondary care. So you should know what's going on outside of your clinic, but not only outside of your clinic. So I have to share with you a patient of mine. He's now 83 years old. He's actually a very nice gentleman, and I know him for almost over 10 years. He was diagnosed a little before that with Crohn's disease, ileal Crohn's disease, and his physicians did not want to treat him because of his age and several comorbidities with more than 5 ASAs, and he was treated with 5 ASAs. He's very active. He was very happy. He has extraintestinal manifestations, so he has arthralgia, peripheral, and he is coming to our clinic a few years ago with clinical symptoms that were treated with budesonide, starting 9 milligrams a day, and he was doing better. However, after 3 courses of budesonide and still evidence for active disease as seen by endoscopy and fecal calprotectin and additional measurement, corticosteroid therapy was suggested to this patient. And this was because we are aware, as you were aware, that there are rising side effects the more you treat those patients, and it's actually true even more so in the elderly patient population. And you see here specifically how we are addressing the loss of bone in the spine when we're using steroids a lot. And this is coming from Miguel Riguero's group now when they were grading steroids. So of course steroids were put in the bottom of the safety pyramid of our treatments, mainly because of that reason, but not only because of that reason. So this patient actually has disease exacerbation, and he refuses further therapy. So we are trying to discuss it with him, and we have a multidisciplinary team, but still he has concerns of side effects. He doesn't want infusion, he doesn't want injections, he doesn't want anything. And he had learned that these steroids have a good effect on him. However, the effect is going down and down. So each time he has an exacerbation, he is using steroids again, and apparently he's treating himself with steroids more than we think of. And when we look at his DEXA estimates, we show that he has significant osteoporosis. And actually, this was clinically apparent as he had a hip fracture, okay? When this was happening, he actually admits that throughout the years, he's using 1 to 2 weeks of budesonide each time he has a mild increase in his bowel movements, even for 4 bowel movements a day. So he's taking 1 to 2 weeks of budesonide, making actually the last few years of this patient exposed to steroids, to budesonide throughout those years with the effects that he had on his bone. So it occurs outside of your clinic, but you should be aware that it might occur in your clinic as well. So we should make small changes that will make difference to patients. Routine follow-up and asking the patient about their corticosteroid use actively is the key. Referral of patients on corticosteroids that are taking them longer term for multidisciplinary teams, but you see that even if you have it, you might fail it. Patient information sheets might be very important for patients on corticosteroids, not only on the new mechanisms of actions that we share with patients. The use of helplines, monitoring of corticosteroid use, and rapid re-access clinics. Like we have a flare clinic where patients can be accessed if they're using steroids, where you can offer steroid-sparing therapy. No, too early. And to summarize, I think that the hidden figures that you may not be aware of what is happening in your clinic and out of your clinic, that prescribing behaviors are obviously not as suggested by the guidelines, that corticosteroid assessment is needed in order to avoid prolonged and repetitive corticosteroid treatment courses. If you don't ask, you don't know. And small changes, of course, may make big improvement for our patients. And actually, I think that what's nice in our discussion today is that we're actually focusing on the patients, what they're really doing, and what we can do to improve their health. And ask yourself when you're leaving this symposium, do you really know why your patients are self-medicating and not telling you, and how we can change that, and with this, perhaps, improve patient care. And with this, I'd like to end, and thank you for your attention.
Okay, good morning, everyone. It's a pleasure to be here at ECCO, at a pre-ECCO symposium. I remember being at one of the first ECCO meetings over 15 years ago in a small auditorium in the AMC, and it's amazing to see how this meeting has grown and changed into such a large meeting, and one of the best IBD meetings, I think, to attend. All right, so we're going to change gears a little bit and speak about how steroids work and how our approach to steroids has been integrated into our clinical trial designs. So as you can see from this slide, IBD is obviously very complex. It's a heterogeneous disease with multiple inflammatory inputs and pathways. And this is just sort of to give you an overall sense of the complexity and the broad nature of the inflammatory pathway through pro-inflammatory cytokines, our adaptive and innate immune responses, and how epithelial cells interact with our microbiota, which is our current hypothesis of why IBD occurs, leading to some structural or functional change in our microbiome and intersecting with genetic susceptibility to cause this unregulated inflammatory process. And there seems to be multiple ways that we can block this pathway, as you've seen from all of the new molecules that are being developed through various cytokine monoclonal antibodies that block the interaction of these cytokines with their receptors and prevent a pro-inflammatory cascade from occurring. Now, what gives steroids their appeal, or at least did give their appeal early on, was that they're very broadly acting. So they shut down many of the inflammatory pathways that are relevant in inflammatory bowel disease, broadly affecting most cytokines that induce inflammation, and probably what accounts for the very significant sort of feeling of well-being that many patients feel upon taking steroids. And their main mode of action is through the glucocorticoid receptor, which is a receptor that's found in the cytosol of many cells, and leads to an activation of, or shutting down of NF-kappa B, which is one of the key drivers of inflammation, and we'll get into that a little bit later. So switching to the clinical approach and how steroids came to be used historically, if we look back to many of the early trials, and these are trials that were done more than 20 years ago or 30 years ago even, and this was a meta-analysis that looked at a summary of some of the RCTs in steroids, and they do show a benefit, particularly in induction, or specifically in induction. You can see that in the ulcerative colitis trials that have been done, steroids are favored and are effective for inducing remission. And in Crohn's disease as well, although in this meta-analysis the overall result wasn't significant, we know that there are two very old RCTs that were done that have led to our use of corticosteroids in Crohn's disease. So we heard from Iris just earlier about the limitations of corticosteroid use, and from Tim about some of the inappropriate use. So there are many limitations despite their appeal with induction. They don't have perfect outcomes, as many of our therapies don't. They don't work in maintenance, and they have limited efficacy on healing the mucosa. And this is a study from Pia Munkholm many years ago, again, that looked at some of the natural history of outcomes in Crohn's disease with corticosteroid use. And as you can see, and I think this should reflect your clinical practice, that roughly half of the patients have a good short-term outcome when treating Crohn's disease with steroids in terms of remission. Another third will be improved, and you'll have about 20% of patients that don't respond. But if you look out to 1 year or longer outcomes, what you'll see is that of the patients that went into remission early on, only about half of those patients remain in remission, with the other half relapsing. And of the patients that improve, roughly 40% will relapse. So when you look at the overall outcomes, up to a third of patients by the end of a year may be steroid dependent, and only about 40% will have a prolonged response, with another 20% or so being steroid resistant. And I think that generally reflects my practice, and I think it is probably representative of yours as well. Now, if we look at the limitations regarding maintenance therapy, we understand that they're effective at inducing remission, but they've never been effective at maintaining remission, notwithstanding all of the toxicity additionally that go along with them. And the figure on the left is from the National Cooperative Crohn's Disease Trial, which was the trial that showed that they were effective at inducing remission for Crohn's disease. But in this trial, in this maintenance portion of the trial, they looked at how the various agents that were used after induced remission were effective. And actually, in this trial, none of the agents that were tested were better than placebo, including sulfasalazine, azathioprine, and certainly not prednisone. And on the right, you can see, again, an older study of budesonide, which is one of the newer generation corticosteroids with less toxicity, and it is effective at inducing remission in Crohn's disease. But this study, led by Gordon Greenberg, showed that the maintenance effect of budesonide was not effective. It did seem to have some benefit for 3 or 6 months after remission was obtained, but when they followed the patients out to 1 year, those patients relapsed, so it was no more effective than placebo. So indicating again that we should not be using either the old steroids or newer steroids to maintain remission for patients with IBD. Moreover, as we know now, our focus is on healing the bowel and getting that endoscopic remission. And these are data from quite some time ago that looked at the impact of steroids on the mucosa. And in this study, from 140 patients that were initially randomized with active Crohn's disease, again, we see that very significant initial induction effect. 90% of those patients had a clinical remission, but when you look at objective endpoints, whether it's biomarkers, you can still see there's biomarker activity in these patients with clinical remission. And of the patients that were in remission, when we looked at the endoscopic outcomes in this trial, you can see that 70% roughly of the patients still had evidence of ongoing active endoscopic lesions, with only about a third of the patients having an endoscopic remission at 1 year. So this really highlights, again, that illusion that we're talking about of remission, where patients feel better, and our clinical activity scores do reflect that, but the objective outcomes that we're looking at really don't reflect the goals that we're trying to achieve with therapy. So as we now try to understand why is it that steroids don't work effectively, we'll ask for your thoughts on this issue. From what you're aware of, what do you think is the most important mechanism for corticosteroid resistance in IBD? Why do steroids stop working? So you can vote now. Selection 1 is the underlying severity. The disease is just too severe to respond. Selection 2 is the steroid dose or bioavailability that we're using. Steroid 3 are inherited or genetic factors in the molecular pathway of corticosteroid metabolism. And selection 4 is acquired or transient effects of cytokines in the IBD pathway, so some type of escape mechanism. So let's hear what people think about this. Very quiet for a large crowd. All right, so it's interesting. Most of the people feel that it's some type of acquired or transient effect of cytokine, maybe some escape pathway, and I think that's a really good hypothesis. The others are also probably playing a role to some degree, and the truth is there is no correct answer because we don't really know why this occurs, and there probably is a role from each of these. And we'll just speak briefly about some of those. So why don't steroids work long-term when they have such a profound clinical effect short-term? So if we come back to how steroids work, as you can see, the glucocorticoid receptor is a cytosolic receptor, and it has many isoforms actually, but there's two major isoforms, alpha and beta, and it's the glucocorticoid receptor alpha isoform that has most of its anti-inflammatory activity, and it works by inactivating NF-kappa B mediated pathways and directly suppressing transcription of pro-inflammatory proteins. It's speculated by some that there are other isoforms, and for example, the beta isoform that actually has the reverse effect, or it does not allow for binding of glucocorticoid receptor interactions with steroids and prevents that anti-inflammatory effect from occurring. So that's one hypothesis, and maybe one of the major ones. In terms of bioavailability, there's been some early data, and our group looked at this quite a few years ago now, that MDR1, the multi-drug resistance 1 gene, is an important efflux gene that leads to pumping of therapy or drugs or other molecules out of cells. And there's been a couple of studies that have showed that MDR1 polymorphisms lead to increased efflux of various agents, including steroids, from the cell, preventing them from being as active as they should be. And maybe that's some process that's upregulated as time goes on. And then lastly, the hypothesis that many of you thought were really relevant, and that's that there's some constitutive upregulation of other pro-inflammatory cytokines that occur with increasing duration of steroid exposure that leads to a more pro-inflammatory effect. And a lot of these mechanisms are related to, let's say, the mechanism of steroid refractoriness. We don't really have a good understanding of what leads to steroid dependence, which is those patients that do respond and can maintain a clinical remission, but cannot wean off steroids without an exacerbation of disease. So switching gears a little bit for the second part of my talk now, thinking about these mechanisms of action of steroids and their clinical effects and induction. How have the use of steroids been implemented in clinical trials, and how do we want to achieve our goal of steroid-free remission with our newer therapies? And it really, this cartoon sort of illustrates this idea that when we all look at something, we're all seeing something different. It's that subjective sense of what we're seeing that could be very different in different patients. And I sort of would draw the parallel to clinical trials. And when you look at a clinical trial result, you have the sense, well, this therapy is working, but when you really dig into it and look at what are the outcomes that are being described, we want to try to understand those endpoints in a bit more detail. So clinical trial design has really evolved over the last decades. If you think back to the early trials from the 1990s, they were generally short-term induction trials with only a few hundred patients in a small number of centers. And as time has evolved, trial design has really become quite sophisticated, initially looking at induction and maintenance sequentially, and then following into re-randomized responder approaches, more designed to reflect our clinical practice, and then into the more recent couple of years where there's been very sophisticated and complex designs with more drug arms, more active arms than placebo, and a lot of opportunities for open label. So really the trials have really become quite sophisticated, very large trials with over 1,000 patients in many cases. But underlying that design mechanism, we should also be thinking about what's being done with steroids. Obviously, many of the patients that are eligible for our clinical trials are on corticosteroids going into those trials. And again, back to the early generation of clinical trials, often corticosteroid-free remission was not even an endpoint, so it wouldn't have even been sort of reported as a significant endpoint or a pre-specified endpoint. And there was no designed or protocolized tapering regimen implemented in the trial at all. And then as time went on and we came to earlier trials, obviously corticosteroid-free remission now became an endpoint that would be reported in the trial, but the use of steroids and how they were handled during the protocol was not mandated, and it was at investigators' discretion frequently in these trials to determine how to taper the steroids, which could affect clinical outcomes. And then now we get into the more recent generation of trials, whereas I'll show you there are very specific mandated protocoled approaches to dealing with the steroids and how they're tapered. So if we turn back to an earlier generation of clinical trials, and in this case referring to the CHARM trial and ULTRA trial for Crohn's disease and ulcerative colitis respectively with adalimumab, what you can see in how steroids were handled in these trials is that, first of all, the steroids weren't tapered during induction. The steroids were maintained at a stable dose through the first 8 weeks of the induction component of the trial. And then in the maintenance phase, it was really at the discretion of the investigator how they would taper, and there was no mandated protocol. However, we do see that steroid-free remission rates were reported. So you could see for Crohn's disease, roughly 1/3 of patients achieved corticosteroid-free remission with adalimumab, and in ulcerative colitis, roughly 13% versus placebo, with up to 20% in responders who continued to taper off steroids during the maintenance phase. Now, probably the first study that really had a very specific approach to dealing with steroids was the COMMIT trial led by Brian Fagan. And in this trial, this was sort of the sonic equivalent of combo therapy, where the investigators looked at the benefit of infliximab with methotrexate versus infliximab monotherapy for Crohn's disease. But what was unique about this trial design was that many of the patients were on high-dose steroids going into the trial. The average dose was more than 20 milligrams of prednisone, and there was a mandated tapering starting at week 1 after initiation of the trial. So it was quite an early tapering approach, and there was a very specific protocol such that all patients had to discontinue steroids by week 14. And this trial actually had some of the best clinical outcomes and corticosteroid-free remission outcomes of any trial, possibly because of that high-dose steroid being used very early, and infliximab and methotrexate being used early, and the steroids being tapered in a very systematic way early on in the trial, such that over 50% of patients achieved a steroid-free remission rate in this trial. Now, if we move down the road a little bit further, and using this approach of a very protocolized and mandated taper, we can see here the Gemini trial with vedolizumab for ulcerative colitis and the Pursuit trial on the right for golimumab in ulcerative colitis. And in these trials, there was a mandated taper of steroids starting at week 6 in both trials, so towards the end of induction. And then you can see that now there is an improvement with this earlier mandated mandated taper protocol. You can see that the steroid-free remission rates get up to 30 to 45% with vedolizumab and roughly 30% to 40% with golimumab. So we're starting to see now creeping up of that steroid-free remission rate with the early induction and mandated taper. And now we turn to the Serine Trials, which again are even earlier or more recent studies. And what we can see here is that now the steroid induction has been moved up further. So again, this is what we want to achieve in clinical practice, start to taper our steroids as soon as we introduce our steroid-sparing agents. And so on the left with the Serine Crohn's disease trial, so the steroid taper had to begin at week 4. So this is, again, even earlier in the induction of the trial with the adalimumab. And again, remember, this was high-dose induction of adalimumab versus standard dose. And you could see that the steroid-free remission rates, in this case measured at week 12 that you've seen presented last year, show that you get to about 50% steroid-free remission rates. And if you contrast this to the CHARM data that I showed you earlier, you can see that we're achieving better steroid-free remissions by getting that steroid use in early and tapering more rapidly. And on the right, you're getting a little sneak preview of the Serine data for ulcerative colitis and the maintenance data that's going to be presented in probably about an hour from now by Jean-Fred Colombel. And again, this was a similar protocol where steroids had to be tapered at week 4. And what you can see in this data, that looking at the week 8 responders and pushing out now to the maintenance outcomes at week 52, you can see that we're pushing those ulcerative colitis results a little higher compared to the ULTRA results, up to 38% steroid-free remission rates. And lastly, if we now refer back to the Varsity trial, which was presented last year, and we look at steroid-free remission, as you'll all remember, most of the outcomes in this trial favored vedolizumab over adalimumab in treating ulcerative colitis. But there was this somewhat paradoxical result with the steroid-free remission favoring adalimumab. It was not statistically significant, but certainly for a lot of people, we puzzled over why this result occurred. And I think one of the problems that leads to confusion in this trial is that there was no mandated steroid tapering protocol. So it was at the investigator's discretion what was done with the steroids, which may have led to this type of result being paradoxical as compared to the other results. And if you look in the supplementary materials and you look at the steroid exposure, what you could see is that cumulative corticosteroid exposure actually was more significant in the vedolizumab group, with their patients on vedo having 440 milligrams cumulatively more exposure during that year of treatment, and also having 24 days more steroid exposure than the vedolizumab compared to adalimumab treated patients. So it's a difficult study to interpret in light of this non-mandated or non-protocolized steroid approach, and this would really reinforce the importance of having this type of approach in our clinical trial design moving forward. So to summarize then what we've talked about today, steroids are effective at improving symptoms, and they do provide this global sense of well-being and improvement in how people feel. However, they are ineffective for maintenance therapy, as I've shown you from the data, and as you've seen, the toxicity can be quite significant in many patients. We don't really understand the mechanisms for steroid dependence and resistance, so the best approach would be not to allow our patients to even get to that point in the first place. I think you've all seen now the relevance and importance of corticosteroid-free remission as a critical endpoint in our trial design, with a very rigorous approach to how steroids are handled in trials so that we don't have this confusion in our results and how to interpret them. So thank you very much.
Attempt to wrap up here. And I want to give you a little take-home message here, which is some practical steps that you can enact, not starting next year, but in fact starting tomorrow, as well as buying your Valentine's card, to reduce corticosteroid exposure in your patients. The first thing is to educate. Educate your patients. Actually, patients are very smart. They understand the risks. They know the risks, and many of them have the experience that we simply lack of corticosteroid exposure, but make them aware of what they should do. So you're being offered corticosteroids by your primary care practitioner, contact us. Let us know what's going on. Educate your primary care colleagues. We know from data in the UK that a lot of inappropriate prescribing goes on in primary care. This isn't to humiliate or beat up our primary care colleagues. It's our role as secondary care practitioners to educate and share the knowledge we have of the risks of corticosteroids, and educate your colleagues. Perhaps the most informative way to do that is simply to undertake an audit and look at the practice within your unit. Assess your patient's corticosteroid response when you do initiate prescription. Mark showed very nicely that response to corticosteroids, although strong, cannot be taken as a given, and don't just regard corticosteroids as a fire and forget therapy. Know your own numbers. If you don't know what fraction of your patients were exposed to corticosteroids and what fraction of your patients had corticosteroid excess in the previous 12 months, then there are very simple tools out there that you can use to help gather that information, and you may well be surprised by the results. And finally, if you are starting a patient on corticosteroids, always have in mind what your exit strategy is. As I said at the start, this is a fire extinguishing strategy, not a fire prevention strategy. Now, I want to wrap up there, and more important than anything else, I want to thank both Iris and Mark for absolutely fantastic talks and sharing their knowledge with us. I'd like to ask you to complete an evaluation form, the second half of that form, if you could do so now, and really thank you for your participation and attendance at today's symposium. The last thing I'm going to show you is this video, which has been put together to give the one voice which is really missing from this stage, which is the patient's voice. So I'm going to leave this playing as we close and wish you all a thoroughly enjoyable rest of the Congress, and enjoy Vienna. Thank you.